Hi, my name is Dr. Jody Russin, and I am an associate professor in human development and family science at Virginia Tech. I am a suicidologist and a family therapist. I focus specifically on developing, implementing, adapting suicide prevention efforts with families, communities, organizations. And so what I'm going to present to you today is our poster, which is definitely falls into that topic area. Our poster is called Affirmative Family-Based Youth Suicide Prevention Training for Behavioral Health Professionals in Southwest Virginia. And this is a preliminary evaluation of a training that we modified and added to specifically address the needs of LGBTQ plus youth in our region. That is lesbian, gay, bisexual, trans identified, and queer and questioning youth who have been experiencing suicidal thoughts and behaviors. So the whole goal of this training was to equip behavioral health professionals with the tools and skills they needed to really be able to help this particular population of youth in our region. So I'm going to give you a little bit of background, and then I'm going to talk you through our sample and our results. I would welcome questions, comments from you. If you would like to send me an email with any thoughts you have, my email is at the bottom of the poster, and I'd enjoy hearing from you. So a little bit of background, we know that suicide is a public health concern among youth populations at large. It's a growing concern, and there's quite a bit we need to think about when we consider addressing it. But for our LGBTQ plus youth in particular, we know that they face elevated risks. And some of the issues that we have to understand with that is that these youth have greater exposure to discrimination, bullying, stigma on the basis of their identity that lead them to experience greater distress, isolation, loneliness, which we know can increase risk for suicide. So there are real reasons why this population might be particularly at risk. And we know also that our LGBTQ plus youth or our sexual and gender minoritized youth living in rural spaces in the country also report greater risk than their counterparts in other regions because they are more likely to face victimization, have less access to mental health care, and are more likely to have thoughts about suicide. And so again, this requires then that behavioral health professionals of all different types have competence and understanding in terms of addressing this particular population with this particular set of presenting concerns. So what did we do? We took a comprehensive youth suicide prevention training with a very strong family engagement component, and we adapted it to the needs of LGBTQ plus youth specifically. Not only did we modify some of the pre-existing content in the training, but we added a module focused on affirmative care, which is all about providing the best care to LGBTQ plus youth. And we did that in collaboration with a large integrative health center in Philadelphia called Mazzoni Center. They have an excellent education department, and they helped us think through the best way to present this training. And then we assessed the training. So before and after participants became involved in this day and a half long training, they completed assessments focused on LGBTQ affirmative care, competence, and skills. They completed assessments about their knowledge, preparedness, self-efficacy, their belief in themselves, about their ability to address suicide amongst youth populations. And then we also asked them about family engagement, their confidence talking with caregivers or parents of youth who had thoughts of who had suicidal thoughts and behavior, as well as how Well, they thought they could motivate a caregiver to take their youth to therapy or another type of behavioral health care. So these were our big outcomes. Long story short, we wanted to assess LGBTQ clinical competence, suicide prevention competence, and capacity for family engagement, because we know when you involve families effectively, they can really help to prevent youth suicide and take kids to get the care that they need. So, who was our sample? In this preliminary study, we had 19 behavioral health professionals. It was a diverse group. You can see who our sample is right here with our pie charts. And then you can see that they have a diverse range of clinical licenses. We had psychiatrists, we had counselors, we had nurses, psychologists, a very broad group. We also know for this group that the majority had quite a bit of experience already looking at the needs of LGBTQ plus youth and serving them in their settings. So there was only one participant with no experience in the entire sample. And then also the majority of these folks had attended a suicide prevention training in the past. So we really saw this group of professionals as being somewhat specialized in serving this population. And so, with that in mind, we can interpret our results. We found that we did have significant changes as a result of the training on LGBTQ competence. That's our LGBT docs measure here. We had significant change. And then also, our participants reported greater confidence talking with caregivers and parents about their youth suicidal thoughts and behaviors. So those were the areas where we saw that there was change. And so what does this tell us? Well, this particular training that we developed was quite effective in helping this group of professionals develop their abilities in terms of affirmative care, even though this was a group that had quite a bit of experience in that domain already. We also wondered if, because this was a pretty clinically experienced group, that we were hitting some ceiling effects with the suicide prevention information, which is why we may not have gotten changes on the gatekeeper behavior scale, the likelihood, self-efficacy, and preparedness to address suicide. And then also we were pleased to see that the training was helpful to providers with regard to being able to talk with caregivers and engage them in supporting their youth. And so those were our findings. Our next step is to test the same thing in a larger sample. This sample was unique to Southwest Virginia and perhaps speaks to the areas that this training could address in a similar sample in our region. We would like to get more participants. And so again, that is our next step. One last note that I'll share is that this project was part of a larger suicide prevention project. And the information for that is right here under the collaborations. We would love it if you left us a comment on your post-it sticky note. Just in one sentence or less, if you could describe in your experience or from your point of view what the most important thing behavioral health professionals should know when working with this population, and it will help us continue to think about how to develop this training, what to measure for those who do participate to see where the training can create change. We would just really appreciate your thoughts. So thank you very much and hope you enjoy the conference.